Hello, thank you for joining this presentation. My name is Nargess. I'm a PhD student, and today I'll be talking about a project where we are looking at using linked data to estimate the true number of individuals who were impacted by residential fires in New South Wales, Australia. I would like to acknowledge my supervisors, Dr. Kathy Dennis and Dr. Laura Harvey, who co-investigated in this project. Fires are a potentially devastating event, and they cause death of approximately 265,000 people each year. And in most Western industrialized countries, a great proportion of fire-related death and injuries are residential fires. In Australia, the rate of fire incidents is approximately 100,000 per year, and 2,000 of those are related to residential fire incidents. 35,000 of the fires in Australia occur in New South Wales, of which 6,500 are residential. Australian studies suggest that the reported number of residential fires and related deaths and injuries significantly underestimate the true number. An Australian population-based study suggests that 2/3 of the households who had a residential fire were not willing to report it. And some international studies from the US and New Zealand indicate that many individuals who use health services as a result of residential fires did not have an associated fire incident report. The objective of this study is to determine the total number of residential fires and associated death and injuries and health service utilization in New South Wales, Australia from the beginning of January 2005 to the end of December 2014, and also to find to what extent there is underreporting of residential fires and related death and injuries across the data sets. In a residential fire event, based on the severity of fire, different agencies might get involved. In New South Wales, individuals might contact fire and rescue as the first responder, and their details would be recorded in Fire and Rescue New South Wales incident reporting system as. If injured, individuals could also use ambulance, in which case their records could be found in either computer-aided dispatch system CAD, or in patient healthcare record PCR, or in electronic medical records EMR. If not treated in the ambulance, they will be transferred to emergency, and the details of their visit will be in New South Wales Emergency Department data collection, EDDC. Some individuals might be admitted to hospital as a result of their residential fire incident, and their details would be recorded in New South Wales Admission Patient Data Collection, IPDLN. Based on the type of injuries, some individuals might be sent to specialist burn outpatient clinics whose details would be recorded in New South Wales Statewide Burn Injury Service, SBIS. Finally, those who deceased would be sent to morgue, and their records could be captured in the Registry of Birth, Death and Marriages and Cause of Death Unit File Record data set. We used all these 9 data sets for this study, and the data linkage was undertaken by the Centre for Health Record Linkage, SHREL. It's worth mentioning that fire incidents in New South Wales that have fire and rescue or rural fire service attendants are recorded in S, and there was a change in platform for encoding of reporting, and for New South Wales, the latest figure available was 31st of March 2015, and that's why the duration of this study is up until the end of 2014. To determine the total number of fire incidents and health service utilization, there is no one way to identify across datasets, and we use a variety of different ways and come up with different methodology to try and identify them. First, the variables that could be used to determine residential fire in each dataset were identified. The result gave us records of those who may or may not have contacted fire and rescue. As shown in the table, in the areas dataset, using residential building keyword as the type of property, we identified 43,897 residential fire incidents involving 43,433 individuals, with some individuals reporting multiple times over the study period. For ambulance, we identified records with building fire keyword in either of the three datasets, which included 1,180 individuals. In EDDC, using ICD-9 and ICD-10 and stomach diagnosis codes and keywords such as house fire, we could identify 10 records. For APDC, by searching for ICD-10 external cause code of exposure to uncontrolled or controlled fire in building or structure, 1,853 records were identified, involving 1,619 individuals. In SBIS, searching for keywords such as house fire in mechanism of injury variable helped to identify 132 records. And finally, for mortality datasets, using similar method as APDC, we identified 143 death records. Each dataset then were merged to the AS dataset based on the date of contacting fire and rescue, and the result indicated individuals who reported their residential fire incident and used one or more health services. It showed 1,727 individuals used ambulance on the same day of reporting residential fire incident, and 1,116 individuals visited emergency department. 1,047 individuals were admitted to hospital, and 48 individuals went to Burns outpatient clinic. 100 people died on the same day of fire incident. We did some sensitivity analysis to determine the changes in health service utilization rates by increasing the period within 2 days, 7 days, and 14 days from the incident, and to make sure that we captured as many records as possible. As shown, we identified an increase in the rate of health service usage across almost all datasets. However, in APDC, currently we only have month and year of hospital admission, and we did the analysis based on the month and the year of the incident. And so increasing 2 weeks of time frame would not change the records. We had requested APDC admission date variable from early this year, and it was expected to be accessed by now, but unfortunately because of the current situation, it has been delayed. Over the study period of individuals who contacted fire rescue, 2,430 used health services and 118 individuals died. There were 2,155 additional individuals who used one or more health service but did not contact fire rescue, and 86 additional deaths were identified. Overall, 4,585 individuals used one or more health services during the study period, and 204 individuals died. This project is a whole population-based study, which is also the first ever study that is trying to look at all these data sets, creating a comprehensive database on residential fires in New South Wales to provide a better understanding of first responder use, health service utilization, and health outcomes. AS and SBIS dataset have never been linked for any other studies before, which is another significance of this study. Since AS dataset is based on address and occupant name, and no unique identifier such as birth, date, and sex is provided, it wouldn't be possible to identify all individuals in other datasets unless their address is provided and matched. Accuracy of coding in administrative health data is also another limitation of this study. The need to integrate fire incident data with other relevant datasets is predominant in unfolding the complexity of fire risk patterns and behavior, which would help fire agencies first in the development of effective policies and prevention strategies, and second in the deployment of interventions to mitigate fire risk in vulnerable areas at the time when it is most needed. This study found that 47% of individuals who used health services and 42% of those who died as a result of residential fire did not have an associated fire report. This highlights the importance of data linkage for accurate communication to policymakers and the public on the prevalence and impact of residential fires. We would like to acknowledge additional people who supported us and have been very useful in this project, as shown on this slide. Please email me if you have any questions, and I'd appreciate your feedback. Thank you.